Thank you, Marcos. I'm Joan Cleary with the Minnesota Community Health Worker Alliance. The Alliance is a Minnesota nonprofit committed to equitable and optimal health outcomes for all communities. On behalf of our board and partners, welcome to today's webinar, Research and Results, CHW Strategies in Asthma Care, a webinar for providers and home visiting programs. Today's webinar is part of our Success with CHWs initiative, designed to build provider awareness, know-how, and readiness to adopt effective community health worker models through informative learning opportunities and helpful web-based resources. The initial focus of Success with CHWs is on integrating the CHW role in asthma care in order to address health disparities. We very much appreciate support by the St. Paul Foundation and Minnesota Community Measurement. Looking ahead, I'd like to briefly touch on several upcoming Success with CHW events. We're hosting a learning session on November 21st at Wilder Center featuring pediatrician and researcher Megan Sandel and certified asthma educator Ann Walton, both with Boston Medical Center, on integrating CHW strategies into pediatric asthma care. And on December 3rd, we're hosting a webinar presentation by Minnesota Department of Human Services on CHW coverage guidelines, including an overview of our statewide CHW certificate program. Please register for these free events. Now, I'm very pleased to introduce today's webinar faculty. Dr. Jim Krieger will begin our program with the presentation, CHWs Bringing Asthma Care Home. Dr. Krieger's asthma-related work focuses on reducing asthma health inequities through environmental and systems change interventions. He has led multiple asthma research studies funded by NIH, CDC, Robert Wood Johnson Foundation, and PCORI that have examined the effectiveness of in-home CHW asthma education programs, how integrated systems of asthma control and asthma coalitions can improve outcomes, and the impact of improving housing conditions on asthma. Dr. Krieger is a graduate of Harvard University, UCSF, and University of Washington. Following Dr. Krieger's remarks, we'll hear from Erica Marshall, who will discuss the role of CHWs in the work of the Asthma Control and Prevention Program at the Massachusetts Department of Public Health. Ms. Marshall has worked in public health since 2007, exploring a variety of topics, including asthma, sudden infant death syndrome, and addiction disorders. She joined the Massachusetts Department of Public Health in 2010 as the Reducing Ethnic Racial Asthma Disparities in Youth Coordinator and has since assumed the role of Asthma Director in the summer of 2013. Ms. Marshall earned her MPH from Boston University. So now I would like to turn over the presentation to Dr. Jim Krieger.
Good morning, everybody. This is Jim Krieger talking to you from Seattle, and thank you very much, Joan, for the invitation to talk to you about some of the work we've done in Seattle and place that in the broader context, specifically research finding on the slide that we're on today. I guess it was to remind this audience, too, I should have detailed that asthma still remains a major public health issue. There's 112 people in the United States, and that translates to 12 million people at a cost of $56 billion a year. And while we thought that the asthma epidemic was turning around when it looked like the asthma prevalence rates were plateauing in the late 1990s and early 2000s, it actually looks like now with more recent data that for the past 10 years or so, the asthma prevalence has begun to increase again, putting asthma in the forefront as a major public health issue and a costly condition affecting the healthcare system. Asthma is not an equal opportunity disease, and it disproportionately affects low-income communities, and that's true whether we're in Minnesota or in Washington. The slide on the left shows the Seattle-King County area, and the highlight of this is that the areas that are in dark orange are places, zip codes that have the highest hospitalization rates
in our part of the world, and those are also the same as where the low-income population lives. If you look at the map on the right for the Minneapolis-St. Paul metro area, again, you can see that asthma hospitalizations tend to cluster in communities that have more low-income people. So asthma is not only an important issue affecting everybody, it's an important driver of health inequity. So we have a paradox, though, when we're trying to deal with asthma. We understand the pathogenesis of asthma much more than we have in the past. We have good treatment methods and effective interventions to control asthma, but as we just saw, morbidity and even mortality from asthma are continuing to rise both in our country and worldwide. Why aren't we doing better? It has to do, I think, with the fact that healthcare organizations and clinicians are not providing the state-of-the-art care. Patients and families are not effectively self-managing asthma, adhering to treatment recommendations, and the environmental conditions that expose people to asthma triggers are not being addressed. Why are we not doing as well as we might? From the patient perspective, many patients continue to view asthma as an acute episodic illness rather than one they have to manage as a chronic disease long term. They have many other issues going on in their lives that are more immediate priorities than perhaps self-managing asthma, and they lack knowledge, skills, and resources to be effective in managing their own asthma. Healthcare organizations and providers are not effectively organized to manage asthma, and they too lack the knowledge, skills, and resources, and particularly at the point of care, to provide the best support they can to their patients. And there's also a cultural gap between patients and providers in some cases, where providers assume that patients will make asthma their top priority and put aside their own beliefs, priorities, and concerns and follow a recommended treatment plan without understanding how this fits in the context of the patient's life. So we've been trying to address some of these barriers and limitations to asthma control for the last 17 years with a series of programs in Seattle and King County. And I won't go tell you about each of our programs, but what I'll do is I'll summarize what we've learned over these last 17 years and how it particularly is focusing on the role of community health workers in overcoming some of these barriers to optimizing asthma care and control. First, I want to take a step back and just remind us of what is a community health worker. They're a very unique health professional. They are a frontline health worker, meaning they're out in the community, out with people where they live, work, learn, and play. They're also a trusted member of the community. They come from the community, they live in the community, they understand and are part of the culture of the community. They therefore can serve a unique role as a liaison between healthcare institutions and the community because they can navigate across both worlds. They also are very skilled at building both individual and community capacity. So rather than a passive model of patient education, they actively encourage patients to develop their skills and self-confidence in managing their condition. So they're pretty unique and special people. And they're hired primarily for their understanding connection to the community and populations that they serve and spend most of their time out in the community and therefore are not a typical healthcare worker. As I mentioned, they share language, culture, and life experiences with their clients. In our case, they all have personal experience with asthma, either themselves or with an immediate family member. They're very outgoing, connecting kind of people who can build trust and supportive relationships with clients. We make sure that our community health workers are well trained and that they're well equipped to provide accurate information to their clients, as well as understand the limitations and not go beyond their professional scope of practice. They each receive, before starting, 80 hours of core training. That consists of both classroom and experiential learning. They learn both about asthma content issues as well as how to be a good community health worker. After they're trained, we do biweekly maintenance training sessions every 2 weeks. We review cases among all the community health workers so they can continue to learn from each other's work. A nurse will go and do a home visit with 2 visits every month to see how their visits are working at home. And 10% of all the charts that the community health workers complete are audited each month by a supervising nurse as well. And how does the actual program play out in the homes? Each community health worker will make about 3 or 4 visits to low-income children and adults with asthma. These visits take place over a period of 6 to 12 months. At the visits, they will initially assess the home environment and get a sense of the self-management skills of their clients. And then based on what they learn, they will offer a tailored education and support for the caregivers or the patient to develop a self-management plan, and using motivational interviewing techniques, tailor that to what the patient's most ready to take on and most likely to succeed at. They also coach patients on improving their use of the healthcare system and communicating effectively with their medical providers. And because these are low-income families, they provide some key trigger control resources to help the families reduce trigger exposure. They provide, importantly, social support, both on their one-to-one relationship with the client and also connecting the client to other social networks and resources. And they address social determinants of health that might affect asthma control, such as obtaining food stamps or referrals to employment agencies or help with domestic violence or working with landlords. Here's some examples of some of the participant supplies that we give to our clients, including home cleaning supplies, a HEPA quality vacuum, pest control supplies, and allergen control covers for pillows and mattresses. Does it work? Yes, we've been able to show through numerous randomized controlled trials over the years that these home visits work. So for children, they decrease symptom days by 21 or more symptom days per year. Quality of life for the caregiver and the child improves significantly in the clinically important ways, and urgent health care use decreases by 40 to 70%. The little bar graph here shows the high-intensity or intervention group compared to the control group in one of our studies, and shows before and after the percent of the children that have had an urgent care use episode, such as a hospitalization or emergency department visit, in the prior 3 months. We also know intermediate measures improve as well, such as caretaker knowledge and action to control asthma, and we also documented decreased exposure to triggers in the home. And this is a cost-effective intervention as well. Let's just take a step back to remind ourselves that asthma is an expensive condition when treated medically. Inhaled steroids over the course of a year, such as fluticasone, cost more than $2,000, and more expensive immunomodulator therapy costs up to $20,000 a year. The home visit is a bargain, costing us now $1,341 per client served. We've been able to do some cost-effectiveness analyses in some of our studies. One project showed that we projected a net savings over a 4-year period in one of our earlier projects of about $200 to $700 per client. More recently, we've done a demonstration project with our state Medicaid agency and have demonstrated that there's a net savings per client of $634 in a 1-year time period, and that translates into a return on investment of 1.9, or for every dollar invested in the program, a payer would expect to receive $1.90 in savings. How about adults, though? Most of the studies, actually all the studies to date, have looked at home visits and community health worker programs for children with asthma. We will be publishing later this month in JAMA Internal Medicine data showing, the first study showing a similar impact in adults. This is our home-based study, or home-based asthma support and education for adults. It's another randomized control trial funded by NIH with 366 participants, and a very similar intervention to what I described for children. We again saw significant improvements in symptom-free days, increasing 2.1 days per 2 weeks in the intervention group compared to the control group, and we saw clinically significant improvement in the quality of life score in the adults who got the home visit as well. Unlike children, we did not see a change across groups in urgent care episodes, although both groups had significant declines in their urgent care utilization. So what have we learned from implementing home visits to more than 2,000 families over the past few years? We've determined that a community health worker can reasonably expect to carry an active caseload of about 50 to 60 clients, and it needs to have some of the characteristics that I've already mentioned in terms of being an effective community health worker. And then it's also very important to have a robust infrastructure to support the community health worker through supervision, a structured work environment, and having good clinical backup, such as a nurse that the community health worker can review cases with. You get the most bang for your buck if you focus on clients who have poorly controlled asthma, not well-controlled asthma, and patients who have persistent asthma, not intermittent asthma. We think an optimal number of visits is around 4 visits per client. And as I mentioned already, the visit content can focus on the key elements of asthma control as outlined by our National Asthma Guidelines from any EPP. We found that that's useful to have a client-centered approach using motivational interviewing and making sure that we address the psychosocial needs and resource issues that our clients face being from low-income populations. That it's important to link to systems such as the school system and the medical care system, and that provision of social support is also critical. Providing supplies such as a vacuum to low-income families is also important because many of them cannot afford these asthma control tools, and having a good data infrastructure to track and follow up clients and make sure they complete the program. We have over a 90% completion rate at 1 year after enrollment in our program. And to make sure there's a robust program infrastructure for quality monitoring and data systems. These kind of programs have not been implemented only in Seattle and King County, and here's just a partial example list of many community health worker asthma programs all across the country, all of which have implemented somewhat similar models with local contextual variation to provide these services. An example of another large randomized controlled trial, a seminal study that resulted in very similar results to what our work has found, is the Inner City Asthma Cooperative Study, which was published in the New England Journal 10 years ago now, which was a landmark study that showed that home visits by community health workers reduced symptom days, and that this duration of the impact lasted for at least a year after the intervention ended at 12 months. So when they measured asthma control up to 12 months after the intervention ended, a persistent difference was noted between the control group and the intervention group in terms of reduced symptom days. The CDC conducted a meta-analysis of studies through 2008. This was published in 2011. They reviewed 760 articles and included 25 studies in this meta-analysis, and it found, again, quite similar findings to what our individual studies have found. The pooled decrease in mean symptom days was 0.8 fewer symptom days per 2-week period, or again, about 21 to 22 days per year. In addition, the quality of life increased again by about 0.6 points, and acute care visits were noted to drop by about 0.7 visits per year in these pooled data. They also conducted a cost-effectiveness analysis across all these studies, and they found that the program cost ranged from $231 to $1,720 per participant, so quite a wide range. They found a cost-benefit ratio of 5.3 to 4.0, meaning a return on investment of $5 to $14 per dollar invested. This is larger than we observed in our study, and has to do in part with the economic models and modeling that were used to conduct these cost estimates. A more recent review by the Institute for Clinical and Economic Review for the Comparative Effectiveness Council in New England reviewed 14 studies, and again doing community health workers. And again, it found across a number of conditions, including asthma, that these type of interventions show the net cost savings over a 6-month to 2-year period relative to control groups. So this leads me to conclude that there's robust evidence that community health worker home interventions for asthma not only are effective, but are also cost-effective and will save those who invest in them significant funds in the short term within a 6 to 12-month time horizon. So I'd like to conclude by saying that home visits by community health workers that address self-management support and also make sure to focus on reducing exposure to indoor asthma triggers will improve asthma outcomes. That we know that from our studies, not only are these effective, but they provide additional value beyond what can be provided by traditional asthma education programs, for example, those delivered by nurses or health educators in clinical settings. That they improve symptom-free days, improve quality of life, reduce exposure to triggers, promote behavior changes. In many studies have reduced utilization. So what I conclude is saying is that while a home visit might not be for everybody, it should be part of the range of a menu of options to provide asthma self-management support to patients with asthma. Home visits can be or might be right for some patients. Patients might prefer one-on-one clinic-based education. Others might prefer classes and those types of group activities. We found that the home visits are particularly well suited for low-income populations who have challenges in attending clinic or small group classes because of logistical concerns and time constraints. We also find that home visits are unique in that they allow more effective addressing of the triggers to asthma found in the homes because of the ability to do home assessments. And they also provide unique insights into the competing life priorities and other challenges that the patients with asthma face, and provide the community health workers the opportunity to really be the eyes and ears in the home and on the ground to understand the full context of the patient's life and use that information to both help the patient directly as well as to connect with primary care providers to give them insight into what's happening with their patient. So I'll leave you with a few issues to think about in terms of implementing community health worker programs. There's discussion in the field about who should be a community health worker. Should they be peer volunteers or should they be paid professionals as part of a healthcare team or part of a community-based organization? Where should the community health workers live? Should they be embedded in a medical home? Should they be embedded in a health department or community-based organization so they can serve multiple clinic systems? Should they be specialists who have deep knowledge of asthma, or should they be more generalists who provide more health systems navigation and more general support to their clients? Should they be certified? Should they be credentialed? And of course, how should they be paid? Because until reimbursement is addressed, this valuable service will not be available to all of those who could benefit from it. And of course, I'm sure you have many other issues you're thinking about, and I hope we can address some of those in the question and answer period. So thank you for your attention, and I look forward to further discussion. So I'll now turn it over to our next speaker, who is Erica Marshall.
Hi there. Thank you so much, and good morning, everybody. I wanted to say thank you again to the Minnesota Community Health Worker Alliance for the invitation from Massachusetts to present our work. I'm going to pop ahead to my slides here. Here we go. All right. Okay. So today I'm going to give you an introduction sort of to who we are with the Massachusetts Asthma Prevention and Control Program, talk a bit about how it is that we've come to prioritize community health worker strategies in Massachusetts, how we've implemented some different community health worker related interventions, what is the broader context for community health worker work in Massachusetts, sort of ground the work that we do in that larger context for you. I'm also going to talk a bit about how the asthma program is developing what we think of as the supportive infrastructure at a statewide level that really we hope will allow this work to continue and expand in the coming years. And I also wanted to talk to you a little bit about our program's goals for community health workers, where we see opportunities for growth in Massachusetts and how we plan to meet those goals in the future. So the Massachusetts Asthma Prevention and Control Program, or APCP, is the statewide asthma program for the Commonwealth. It was established in its current form in about 2008 with funding from the CDC. The mission is to improve the quality of life for all people with asthma and reduce asthma disparities in Massachusetts. And we do this in a number of ways. One of the major vehicles that we have to advance our goals is the statewide asthma partnership, the Massachusetts Asthma Action Partnership, which brings together hundreds of individuals from many, many organizations that are all working on asthma-related issues to strategize and implement different activities and work that could be done in a variety of spheres to advance common goals, many of which deal with reducing asthma disparities and just improving overall morbidity and mortality for folks with asthma here in Massachusetts. And we're also really committed to addressing disparities and providing sustainable funding for asthma education. And often that comes through in the work that we do with community health workers. So the last point to note here about our work is that the asthma program has, in 2009, we developed both a burden document, which documents all of the data that was available to date in terms of surveillance, for asthma here in Massachusetts, and really gave us a great snapshot of where we were in terms of asthma prevalence, and a number of other measures. And we've just very recently been working on updating that, so that new burden report will be due out in print very soon in the coming months. And also we have the strategic plan for asthma in Massachusetts, which you can see the cover here, which we've also very recently updated, also due in print very soon. This is our strategic planning sort of guiding document. It's really a living document where all of those stakeholders that participate in MAP and work with us kind of lay out our vision for the next 5 years and how we plan to tackle asthma-related issues in Massachusetts. And I will talk about this a little bit later in the presentation, but wanted to give you that grounding that these are sort of two of the main pillars of the program, are this burden document and also our strategic plan. Okay. So in 2009, when the sort of new configuration of the program was really getting going, it was noted by Jean Zotter, who was my predecessor in this role as director of the asthma program, and others here at the Department of Public Health, that asthma disparities, as Dr. Krieger had mentioned earlier, really do exist here in Massachusetts as well. We see them most clearly in the disproportionate prevalence in asthma for Black and Hispanic children compared to white children. And also in Massachusetts, rates of asthma-associated hospitalizations and ED visits for Black and Hispanic children are 2 to 4 times higher than those of white children. So we really see some pretty serious disparities in both prevalence and asthma outcomes for kids in Massachusetts. So within that context, the asthma program began exploring opportunities to build on the growing research, heavily influenced by Dr. Krieger and his team in Seattle, and I always want to say thank you for that, especially in terms of generosity of sharing lessons learned and best practices, and all of that has been very influential to us here in Massachusetts and very helpful. So at that point, the asthma program began looking at 2 different projects that were initiated between about 2010 and 2012 or 13. So the Reducing Ethnic and Racial Disparities in Youth Study, which I will talk about in more detail in just a moment, and then also an Asthma Disparities Initiative, which looked at taking the CHW-led home visit interventions, very similar to what was described by Dr. Krieger, and linking that to policy efforts at the local level. So connecting local asthma coalitions at sort of the city level in this model with clinics that were then implementing the home visiting intervention and really engaging the community health workers in the local policy efforts to see if that could enhance the model or really lead to some more sustainable adoption of the model in local communities. So we really wanted to look at what were the benefits of kind of linking up these groups. And an evaluation of that project found, the community health workers really create these bridges between families, clinics, and then ultimately the communities in this model. And this particular project was funded by the CDC. So I wanted to talk in a little bit more detail about our READY study and the cost analysis. As was mentioned earlier, this is how I first came to join the asthma program, and so it's very near and dear to my heart. So READY is a home-based community health worker-led asthma intervention. We built on the work of Dr. Krieger and other models and really wanted to look at integrating community health workers into the medical home and really putting them into the medical care team. So we worked with 2 large health centers in urban centers in Massachusetts, Boston Medical Center and Bay State Medical Center. Both of these communities have large Black and Hispanic pediatric patient populations. We worked on this study took place over about a 4.5-year timeline. During that time, we enrolled 285 children and their parents or caregivers. And the intervention consists of 5 visits where there's a really intensive educational component, an asthma self-management component, and asthma management education for parents, and then also a lot of emphasis on trigger identification and remediation. We also use motivational interviewing as a means of really, working with families to initiate that change. And we do also supply a basic set of supplies such as pillow and mattress covers, vacuum cleaners, etc. And so in the next slide, we have some data. Now, this is very preliminary. So the READY study is wrapping up in April of 2015. So this is data from sort of the first wave of analysis for the study, and the second wave of data is rolling in and is not ready for sharing broadly yet, but things are looking very good. But what you'll note here is that we're seeing really large reductions in ER visits, hospitalizations, overall urgent care use, and one of my favorite things to sort of point out on this slide, which I think is important to note, is that we've really increased the number of families that have received an asthma action plan, but we also ask about the last time that your child's symptoms, last time your child was not doing well, did you use the asthma action plan? And we see a large, increase in the percentage of families reporting that they actually use the asthma action plan. And I think that's a real testament to the work that the community health workers are doing with the families directly. I often point to the asthma action plan piece as one of the clearest places that we see the work of the community health workers sort of shining through in our data outcomes. So I would say that, stay tuned. We're hoping to have more data available very soon. Early spring, we're also working on a cost analysis using claims data from our Massachusetts Medicaid group. So over 90% of READY participants are Medicaid patients, and so we're working on that as well. But things are looking promising. So in addition, as both the ADI project and READY started to get going, it became very clear that one of the issues that we struggle with in Massachusetts, which I think is universal, is sustained reimbursement or sustained funding for these projects. Many here in Mass are grant-funded or time-limited, and the asthma program, along with some other partners, wanted to initiate a discussion with Massachusetts insurers to find out, how do we get to the next level where we work on reimbursement for what we know the evidence base continues to emerge that this is very effective, and particularly for high-risk populations. And so a meeting was called, and out of that meeting, it became clear that many insurers in Massachusetts were open to payment for a community health worker-led asthma home visit. Some of them still needed to be convinced about the effectiveness of the intervention. Some really wanted to see more of the cost data. So that is where, the READY study is hoping through our robust cost analysis that we're developing now to really answer some of those questions there. But there were definitely, a number of participants in that meeting that said that, yes, they were ready to move forward on reimbursing for this, but there were still some other barriers, and that included insurers really wanted to standardize training, or they wanted to know what skills and what knowledge the community health workers that would be doing these interventions had. They also wanted some sort of standardized way of assessing those skills or evaluation. And they were also looking for a referral system to be easy to use. They wanted it to be easy to identify trained community health workers in the areas where they needed home visits to happen, and they wanted that to be a really streamlined process. So we took all of that to heart and got to work on addressing some of those issues. So I want to step back just for a second and give you a little bit of context about the broader community health worker movement in Massachusetts. And this is a little tough just in terms of streamlined sharing this with you, because it's really sort of happened in parallel tracks. There's been a lot of work that has happened broadly with community health workers that is not asthma specific, that intersects with the work that we've been doing. And then there's also been some interesting movement with community health workers that has been asthma-specific, that the asthma program has either been directly involved with or sort of tangentially involved with. And I'm going to try to lay that out for you to paint that full picture of where we are. So the great news is community health worker movement is, very robust in Massachusetts. In 2000, the Mass Association of Community Health Workers, or MACHWA, was formed. And this is just a wonderful group that brings together community health workers in many fields and really just kind of is both a place that community health workers can meet and network and advance the field together, but also provides a lot of wonderful information and support and sort of makes the case for why community health workers are such a unique and wonderful resource broadly. So Massachusetts healthcare reform law specifically mentioned community health workers, the ball started to get rolling there. There was a study that came out in 2010 that included recommendations on workforce sustainability in Massachusetts. And in 2010, Massachusetts passed a certification law. And the certification law establishes a board of certification for community health workers, which will sit at the Board of Licensure. I'm not getting that quite right. I can put up a link that has more details sort of at the end of things. And so basically, for all community health workers, this is not disease-specific at this point, but it will establish standards of education and some form of assessment, and so that folks that will be able to say that they're a certified community health worker. So this isn't an exclusionary sort of approach, so folks will be able to say that they are community health workers and still do the work, but it will, in order to say that you are a certified community health worker in Massachusetts, you'll need to either complete these standards that are being put in place, or there's also a grandfathering or mothering process that's happening for folks that are already working in the field to also be able to get that distinction as a certified community health worker. So that is happening broadly, and we do hope that someday, right now there is no disease-specific designation, but we do hope that by working closely with the certification board that we will someday see disease-specific certifications, and there may be an opportunity to see an asthma-certified community health worker designation come along in future years. So in addition to sort of broadly what's happening with community health workers, asthma-specific community health workers have also had this wonderful sort of growing movement. And a lot of it has to do with a strong group of very committed local asthma coalitions, our broader statewide partnership, many providers and advocates on the ground here in Massachusetts that have really been beating the drum for many years now about how important the use of asthma community health workers are to improving, outcomes and quality of life for families in Massachusetts. So through a number of efforts over the years, folks have really worked on raising that awareness, supporting legislation, developing best practices and business cases, really going out and making the case for this model. In 2010, the Massachusetts legislature passed an outside section to a budget bill that established a bundle payment pilot for our Massachusetts Medicaid project to take on looking at a bundle payment which would include community health worker asthma home visits as part of the package of services that are provided for high-risk pediatric asthma patients. So I'm going to go into a little bit more detail about that here. So MassHealth is Medicaid in Massachusetts, and this outside section established a MassHealth Children's High-Risk Asthma Bundle Payment Pilot Project. This really looks at the way that these services are paid for, and it's going to be a number of sites will be granted to kind of pilot this approach over several years. In the first phase of the project, uncovered services will be paid for, so this is where MassHealth will start paying for community health worker asthma home visits. They'll need to pay for at least one home visit for patients that are identified as high risk. The pilot project has worked closely with us in the READY study to sort of work on that definition and then also adapt our protocols or our approach to doing these home visits. And included in that is the list of supplies that are handed out to families, the inclusion of motivational interviewing, really intensive training. So this is a really rich opportunity for us. The second phase of the project really looks at how do you get at the payment structure of bundling all of those services that a high-risk pediatric asthma patient would need together. And that would include services that have traditionally been paid for, and then these new services such as the home visits. So this project is really about to get underway, I would say, in the next several months. There have been a number of delays. A part of that is because it's incredibly innovative. So the way that it sits at Mass Health, it requires CMS approval, and that can be lengthy, and there's just many, many things that need to fall just into line to get this moving. So this is a really wonderful project that's been in the works for a long time, but is just about now to get really underway, which is very exciting for us. I also wanted to mention the Health Resources and Actions New England Asthma Innovations Collaborative, which is funded by a CMS Innovation Award. This is really a regional approach to implementing these community health worker-led asthma home visits. So 4 states in New England are part of this project. Each state is able to adapt and kind of implement the community health worker visits in their own way as regionally appropriate and working within the context that exists within their state. So there is a great emphasis on getting payer and payer input and sort of a robust cost analysis out of this project to really make the case for why these are services that should be reimbursed for. And this project is great in that from the outset, a number of payers were at the table, really making commitments to if we see a return on investment, then we'll pay for X number of visits, and et cetera. So they were really engaged early and have been active participants in the process, which is great. And I think that is this project is just now starting to get some of their data analyzed, and so I would say keep an ear for this. More to come from them, especially in the next year, and it looks to be very interesting at this point. So then the last thing I wanted to mention is the Prevention and Wellness Trust Fund, which was established by the Massachusetts legislature. It's administered by the Department of Public Health. The goal of this is $60 million over 4 years for evidence-based community prevention activities with the goal of reducing costly preventable health conditions. Included in that is pediatric asthma. So there are 4 priority health conditions that these granted communities must address, and pediatric asthma is one of those 4 priority conditions, which was really amazing. I mean, it is wonderful for us to think that it's a lot of resources, a lot of dedicated effort to really make a difference in these communities. So 6 communities of 9 funded sites are going to address pediatric asthma in the next several years, and 5 of the 6 sites will use community health workers. And what's interesting here is that a number of these sites will use community health workers in the traditional home visiting model that we've been talking about, but several of them are also looking at innovative ways to make that a final linkage to schools, so initiating home visits from a school referral or trying to really tighten those linkages between providers and schools and exploring ways that the community health worker home visits fit into that broader context. So the asthma program is providing a lot of technical assistance and support to this project, and we really see it as a very innovative and exciting opportunity for us to make a difference in these communities in the next couple of years. So as I mentioned earlier, I mentioned the strategic plan very early on, and in the last year, we've done a lot of work with our statewide asthma partnership to realign our goals and objectives and planned activities for the next 5 years. And one of the things that emerged through that process was this desire to have a goal that really pulls out specifically the reduction of disparities in asthma outcomes. And so throughout this process, it was identified that one of the best tools that we have that we know is having results are multi-trigger, multi-component home visits for children that are led by community health workers. And we think that if we provide, in the next 5 years, 5,000 visits, we'll see a population-level decrease in ED rates for Black and Hispanic children in Massachusetts. So we unveiled this plan over the summer. We have a number of partners that are providing these home visits and are committed to providing them. And this is a big goal. I mean, this is a really, it's a 5,000, sort of stops people in their tracks a bit. But I think that we can do it, and we definitely, are making some great progress. And I think that it's something we can move the needle on in the next 5 years, and we've got that commitment now from a broad number of partners and stakeholders across Massachusetts to work on making that happen. Also this year, I mentioned that the APCP's primary funder is the CDC, and we have a large grant that sort of is 5 years, and we just reapplied for that grant this year. So it has been a year of sort of realigning priorities and activities, and currently we are implementing our new 5-year grant. One of our goals for the next 5 years is universal access to quality community health worker-led asthma home visiting interventions across Massachusetts. And we've identified some strategies for how we plan to meet that goal. We're going to have a strong emphasis on reimbursement. We're going to drive demand for home visits with payers and providers, really making the case for why this should be provided. We're working on building the training and implementation infrastructure that insurers have noted they really want and need to see widespread adoption of this. And we're going to continue to support ongoing asthma home visiting initiatives through a learning collaborative that will really build on the work that we've done in other projects and help folks zoom in on that quality improvement piece to get the best outcomes that they can when adopting these models. So as we approach the reimbursement and driving demand priority, we're going to be promoting the adoption of a provider-focused, promoting the adoption of this model through a provider-focused white paper, partnering again with the NEAC project and the Asthma Regional Council of New England on a regional business case, looking at our surveillance and health claims data to target particular insurers and providers. We have something that I know is becoming more available in other states as well, which is the all-payer claims database. So claims data for all payers in Massachusetts has been aggregated, and we're just now being able to sort of dig in and see, but the thinking is that we will be able to look at the patient profiles for particular insurers, identify those that have really poor outcomes for asthma, high costs associated with asthma hospitalizations and ER visits, and really target them with the model of community health worker home visiting, and really bring the case to those folks that are most in need of adopting this model. So that is one plan. We also are working on an e-referral system, which will link clinicians, and for right now, our prevention wellness trust sites. But this idea of e-referral is a bidirectional information sharing software that integrates into the electronic medical record that the Department of Public Health has been developing for other projects. The idea being that a physician that's seeing a patient would be able to initiate a referral to an asthma home visit with a community health worker. If that community health worker is at a community organization, that community organization would be able to perform the visits and then send, through an electronic form, send information back to the provider about that visit to really strengthen that communication so that everything that the community health worker is able to do in the field and capture can be communicated directly back, really tighten up those linkages to improve outcomes for this population. So we're working on the development of that technology now and hope in the next year or so to really have a product that we can share more broadly. And we're going to continue to address those provider-identified barriers to adoption of this model. So one way that we're doing that is through community health worker training. Over the past several years, we've worked with Boston Public Health Commission to develop a comprehensive 4-day training program for asthma home visitors. Also included is a 2-day supervisor training and quarterly in-person support meetings. In the next year, actually, we're really working on boosting a mentorship component, so a hands-on, practical, in-the-field mentorship by a senior community health worker of new community health workers to introduce them to the model. We're also working on an observation-based skill assessment. These are both things that insurers had mentioned that they saw as barriers to adoption, so we want to really build what we see as the infrastructure that supports full adoption of the model. And then, as I mentioned, we're convening an asthma learning collaborative, which is going to pull together folks that are participating in the Prevention and Wellness Trust and also the Mass Health Project to really work together to learn from each other as they go forward, implementing these models and working on quality improvement of the models. We have a lot of lessons learned from the READY study around retention, enrollment, how to reach families, how to improve communication, and we see this as an avenue both for learning with those groups from each other, but the asthma program being able to pull up some lessons learned more broadly so that as more and more groups across Massachusetts adopt this model, we have sort of a more robust toolbox of things that we can offer them as support. We're also working on a standardized asthma home visiting toolkit for Massachusetts. We're convening about 15 different groups right now that do community health worker-led asthma home visits and working on consensus around what are minimum components that should be included in a multi-trigger, multi-component model. As we look for wider spread, there are many groups that are taking on adoption of this model for the first time and looking for resources, and so we're trying to put together, with the consensus of folks that are doing these visits on the ground, sort of a standalone toolkit that can be a basis for information and support.
Erica, we're going to need to move into Q&A in just about 30 seconds, so I ask that you wrap up your wonderful presentation.
Oh, that's it. So this is that's it, just to say who we are and where we get our funding, and that's contact info. So, sorry, thanks.
No, that was excellent. Thank you so much, Erica and Jim. Thank you for your leadership on research and on policy in your own jurisdictions, of course, and then more broadly across the United States. Very impressive and a lot for us to learn from here in Minnesota. A few quick words, and then we'll move into a question or two that we have time for. As some of you may know on the line, here in Minnesota, we do have Medicaid payment for diagnostic-related patient education provided by CHWs. So that is a funding stream that is available. And then we also have standardized training for CHWs. So with that background, let's see if we might have maybe a minute worth of response from you, Erica. If you might comment on the extent to which private payers are involved in the bundled payment experiment in Massachusetts. And will the bundled payments include durable goods related to healthy homes?
Yes, so at this point, no private payers are involved in the pilot. It's just for Medicaid, and it's also just for, it's not for managed care. It's just for their, PCC plan. So they have signaled that there is, depending on the success of the pilot, interest in expanding to the Medicaid managed care groups as well. So we have, fingers crossed for that. And yes, durable goods are included, and included in that are vacuum cleaners, dust mite covers, and some durable sort of cleaning, some cleaning supplies and related materials.
Excellent, thank you. Jim, a quick question for you. We have someone here wondering to what extent the programs that you described and that have been evaluated have been implemented beyond the pilot or short-term grant funding.
So I think that's a great question. I think Erica's work, attests to how this kind of work actually can be taken to scale. And so these kind of programs have been developed widely in Massachusetts, but they're also being implemented to our last count, in at least 60 to 70 jurisdictions across the country, with a combination of grant funding and some various local funding mechanisms, either with managed care plans picking up some of these funding or state Medicaid agencies picking this up. But I think, as Erica alluded to, I think reimbursement remains an ongoing and huge challenge, and that as the Affordable Care Act rolls out and states implement their state improvement plans and innovation grants, that these are going to be opportunities to more fully integrate these programs into the healthcare delivery system in a more routinized and predictable kind of way.
Well, thank you so much. I think that's a great note to wrap up on, is the opportunities for scale-up given the indisputable evidence and ROI. So with that, we'd like to thank our guest speakers and all of you who have joined us today for this webinar. And please join us for our upcoming events as described earlier in the webinar. Have a great day.